Well, my name is Dr. Fraser Birrell. I'm a consultant rheumatologist and honorary senior lecturer with Newcastle University. And it's a very great pleasure for me to introduce you to our MRC Festival of Science event. For the first time, we're holding a mock group consultation, which is being live streamed. So thanks to everybody who's agreed to be filmed and for us to share the experience. You'll have seen from the programme that this provides an opportunity to ask health-related questions, experience how a group consultation works, and also hear some talks from experts in musculoskeletal research from a wide variety of backgrounds. So we hope that you'll find it stimulating and interesting. Now, first question to the audience, with a show of hands, who here has ever attended a group consultation? And by that I mean a session with the doctor or the nurse where there's more than one of you there at the same time and you're getting the care that you'd normally get one-to-one in a consulting room or a hospital. Has anybody ever attended one? I know I have. Okay. Great. So we've got people who haven't had the experience, and our intention was to spread the experience. And my experience is now, I've been doing this for a decade. We did our first pilots of group clinics up in Alnwick and Berwick in 2008. So after we won a national prize for innovation, we then embedded this in routine practice, and the service was commissioned. So we've been doing this for a long time, and we're doing it at scale. What's different now is over the past 3 years, there's been a much bigger understanding that this can work in different settings. And so as an organisation, Shared Medical Appointments UK are starting to share this training quite widely in primary care. And last year we trained 67 practices in the Northeast to deliver care this way. And the model they use is called a shared medical appointment. But I don't want to kind of confuse you with too much information, too much science. There's lots of different names for it. But the key is if you spend time with other people with similar conditions, you learn a lot from them, from the questions that they ask. The clinician, whether it's a doctor or a pharmacist or a nurse, has more time to explain things, and they're not repeating themselves repeatedly, because actually common things are common. And so the common problems get asked by other people and get answered for everybody. And it creates time for a much better discussion about what choices you want to make for healthcare, what we call shared decision making, which is increasingly a theme that's important in the NHS of today. So the point of today is to make things clear to you and give you an example of what's happening. Across the UK, we now have over 500 general practices who are trained, and we've got some very prominent examples of people doing this very successfully in hospital. There's both pre-renal dialysis group clinics being run at the Freeman now. A paediatric incontinence doctor has started doing them, and the first time she ran it, she saw 18 families in one go in a 1-hour session. Everybody was satisfied, and that meant that instead of waiting 3 months to be seen, the waiting list has vanished. So it's all about delivering better care in the right time, in the right way, and better access. And my patients, when they're flaring, can come to the group clinic because they know that they're being run in all the main hospitals now in Northumbria every month. So it's a flexible way to see people. The key is we need to understand there are certain ground rules. When you deliver care in a very different way, there are some core ground rules. So first I'm going to explain what the usual ground rules are, and then I'll explain a little bit about what's different today, because we're doing a mock group consultation and it's being web streamed. So the first ground rule usually would be that we'd say this is a shared experience, so the confidentiality is shared. And that's important because if you've got something truly confidential that you're so embarrassed or so shy about, you don't want to discuss in front of other people, and would only discuss it one-to-one, that option is still available. And in our group, it might be done when you go out to have an injection with a nurse. It might be done at the end when you flag there's a truly confidential issue. Otherwise, everything else is going to be discussed and shared in the group. But you wouldn't use it inappropriately outside the group. You wouldn't gossip with your neighbours. Oh, I heard so-and-so say this in the group. Yeah? Once people have seen that, they understand it. And there have been no issues with confidentiality. Even in America, where these models come from, there's been no issues because it is something that people understand. So it's absolutely clear about shared confidentiality. The second thing is, you're only going to get answers to your health problems if you ask the questions. So please do ask the questions. Thirdly, if anybody speaks too much, and that includes me, then not everybody's going to get a fair crack of it. So it's all about managing it to make sure that everybody gets a fair say and nobody takes advantage and talks too much. Okay? And then the final ground rule we operate under, and I hope we can agree it today, not sure, is that we're going to have permission to laugh and joke. Okay? And what I tell my patients is, I'm not very funny. With them, that always gets a laugh. But you're a tough crowd. But are we going to, because the trouble is sometimes humour is a double-edged sword, and occasionally people will get offended. And if I offend anybody ever, I'm just going to apologise straight away. But are we going to agree that we're going to laugh and joke and we're going to enjoy the session? Great. So that's the usual ground rules. The only difference here is that because we're web streaming the consultation and it's being shared, we've come up with a different way of asking questions. Usually people would just put up their hand and mention it. We've come up with slips and people have put it into a little goldfish bowl. And we were joking earlier about it being a test whether you could get it into the bowl and then pick it up again afterwards. But if there are other burning questions that people want to be answered and they're happy to take a microphone later on, then we will try and answer all the questions today. That's a key thing of the model, is having time to do that and increasing your understanding. With the data that we've been gathering over 10 years, we've got pretty clear evidence that the care is better. The satisfaction levels are the same or better. The outcomes are better, measurably so for inflammatory arthritis. And when you use a tool called the Patient Activation Measure, which measures how good you are at managing your own health, at the beginning and the end of one of the 2-hour sessions that we run in hospitals in Northumbria, there's a great big step up in patient activation, which we believe reflects the greater knowledge, the greater empowerment, the greater ability that people have to self-care after coming to this kind of session. And obviously there's been a lot of debate in the press. Obviously our title today was the evidence behind the headlines. One of the headlines in the press is, although there's lots of new money coming into the NHS, it's still not quite enough. And they're hoping that the new Prime Minister, whoever that is going to bring more resource to the table. Okay, see, now we're laughing. Okay, thank you. But one of the key things is we need to work smartly. We need to use the existing talent that we have. We need to leverage that talent and that clinical experience widely. Okay, so how we're going to run this is that we're going to firstly try and answer your clinical questions. And for that, I'm very grateful to have Tanya Jones, who's an honorary senior clinical pharmacist with Northumbria Healthcare. And she's also a PhD student. So she's going to appear twice here. She's going to talk about the science as well. And we're going to try and answer all your questions. Okay? And hopefully you'll be satisfied with the answers. So I'm going to head into the questions. Are there any queries about how we're going to run this? After we've answered your health questions, then we'll smoothly transition into the science. We'll introduce the very, very experienced set of scientists we have from various different levels. And you'll get a chance to hear a summary of what they've done, their personal stories, and a chance to ask them questions afterwards. As we're trying to make this accessible to everybody, please, if there's something you don't understand, raise your hand and let us know straight away. But what we'll be trying to do during the science sessions is let them talk just for 5 minutes otherwise and answer your questions afterwards. Is everybody happy with that? Great. Well, let's begin then. So the first question, I've got a small lump on my left shoulder, no pain. The GP says it's osteoarthritis, and after 4 weeks, it subsided to 1/8 of the size, and then yesterday it started rising again. X-ray confirmed the diagnosis. There's no restriction of movement. Okay, so that's an interesting one. Shoulder problems are incredibly common. Who's had a problem with their shoulders in the last week? Okay, so it's actually 40% of people, and it includes the young as well as the old. Okay, the common problems around the shoulder are to have tendonitis, and that's inflammation of the tendon sheath. Because the shoulder is a very mobile joint, it's designed to have a huge range of movement and allows us to do lots of important stuff, eating, keeping ourselves clean, washing and dressing. So pain in the shoulder, and obviously this question isn't about pain, but pain is common and sometimes comes on through use, and that tendonitis is common because of the massive range that we have. And the slightest injury or malalignment can cause the start of tendonitis. So that would be treated with rest, ice, compression and elevation, and sometimes exercises to strengthen things. Because one of the big issues with shoulder problems is you get weak and you get restriction of the shoulder movement. What you would call frozen shoulder. Has anybody been diagnosed with a frozen shoulder? I'm not going to ask you to put your hands up now. There's a few people on. So the key is, physiotherapy is often the core exercise for shoulder problems. And sometimes we would inject if the inflammation is very severe. But in general, it's doing the exercises and restoring the range of movement and the power that's important. The lump coming off your shoulder is a very interesting thing. And when you have a lump that comes on quickly and it goes away or changes in size quickly, I can tell you for sure it's not a bony lump, it's fluid. And the common things which bulge out are what are known as ganglion or synovial cysts. Okay? That's the kind of thing that occurs and bulges out over that time scale and goes down. And it's more common if you've got an inflammatory problem in the shoulder, which increases the pressure and causes it to push out. What's interesting is, the comment is the X-ray confirmed the diagnosis. I'd have to say that's unlikely, because X-rays are not good for looking at the tendons. They're good for the bony structures. They're not good for the tendons or even really the space of the shoulder, which is partly a fibrous joint between the collarbone and the shoulder, partly a synovial joint between the head of the humerus and the scapular cup, and partly the articulation of the whole shoulder blade on the chest wall. There's a great big muscular attachment that lets you do that final piece of movement. So that's a helpful. I think it's a comment rather than a question. But is there anything more people wanted to ask about shoulders? Or have we dealt adequately with that part of the body?
Can I just ask that?
Yes.
I raised that question. You say it's a cyst. So
Very light. Yes.
how is it treated?
Well, the simple answer is if there's no pain and there's no restriction, you maybe don't need any treatment. The worry would come if you have swelling, which is persistent, or you have persistent swelling of other joints. So one of the key things I see as a rheumatologist is people who have persistent joint swelling that lasts for 2 weeks or longer. And if that's the case, and your doctor confirms you've got that type of swelling, you would usually be referred to see us quicker to make sure that there's no other problem underlying it. But I think a localized problem where there's a lump that's fluctuating a lot and it isn't giving you great problems, you wouldn't necessarily need to seek particular help for that.
Okay. Can I make an observation?
Of course.
I work.
Use the microphone and then we'll all be able to hear.
I worked 40 years and I had 4 days off during those 40 years. Very healthy.
Brilliant.
Then I retired and I fell off a ladder putting Christmas lights up for my daughter. And
I'm sorry, I don't mean to laugh.
I don't know.
But the image in my mind, that's awful.
I know.
I'm so sorry.
It was, I can assure you. And now with my shoulder, I have limited movement. That's about as far as I can stretch.
So that's a frozen shoulder.
Yeah, I had a 6-hour operation. It's not so much the shoulder. I'm learning to live with the restricted movement. But it's the process, this group consultation. Immediately when you described it, I thought, well, when I was referred to physio, I was taking up 45 minutes of one person's time. And within about 2 weeks, I ended up with a gang of people with shoulder injuries. So it was like a mass approach to treatment. I thought, this is saving a lot of money.
Brilliant.
And I've got some kindred spirits around here. So the model.
And how many people were in that group? Because that's a really important example that you're sharing, is that actually already it's being incorporated in rehab.
Yeah, there was about 8 people turned up for that particular session. And the session lasted a couple of hours.
Right.
So, I was saying, well, 8 people, 2 hours, rather than 2 people, 2 hours.
But the effects are more powerful as well, because there's an element of competition and of helping people with little tips for how you do things.
Yeah, and I found the model worked.
Great.
So.
Thanks for that. But you didn't put your hand up at the beginning. Because it wasn't called a group consultation, was it? So the key is, that has all the elements, I would say. So I'm going to ask again at the end, once we've had a big discussion about what constitutes group care, about who's had the experience of it. Because I did have the experience last weekend of speaking at a conference in Auckland, in New Zealand, and there was only 2 people who said that they hadn't heard of the model. And when I spoke to him, it was a professor of endocrinology afterwards, he said, oh yes, of course, I spoke to him afterwards. He said, oh yes, of course, we were doing that 35 years ago, but we didn't call it that, okay? So it's about understanding. Sometimes our language gets in the way of our understanding. And if you're getting all the treatments you'd get otherwise, but in a room together with other people, you see greater benefits, and it's group care. Thanks for that. So I'll move on to the next question. I have osteoarthritis, and my GP told me to eat more dairy. But I now have a high cholesterol and need to cut down. What am I supposed to do when I have 2 conflicting conditions? Gosh, well that's a fascinating question. As this gentleman did, people are very welcome to identify themselves, but to preserve the opportunity of anonymity, I'm not going to try and ask who the question was from, but if you want to follow up and identify yourself, you're very welcome to do so. So one of the key things here is that eating more dairy is not something we do for osteoarthritis. Okay? So osteoarthritis is the very common problem that gives us use-related pain of the hips and knees, and it gives you nobbles in the tips of your fingers, and it gives you bunions. And it's the commonest reason for hip and knee replacements. It's not treated by dairy. Okay? So I think what's happening here is that the advice was about osteoporosis, where actually calcium intake is important. Calcium and vitamin D intake is important. And in that setting, where you've got weak bones, then you do want to make sure you're having enough calcium and vitamin D, because otherwise that massively increases the risk of you having fragility fractures. So by a fragility fracture, I mean if you've fallen from standing height and broken a bone. So it's not a high trauma fracture. You know, if you've been in a road traffic accident and you come off your motorbike at 90 miles an hour, everybody's going to get a fracture. But who here has had a low trauma fracture who's happy to kind of admit to that? Okay, nobody wants to admit to it. Okay, there's a few. Okay. So the key is it's common, and in this kind of age group, we're looking at really at least half women and probably between 1 in 4, 1 in 3 men who have osteoporosis risks. And that includes fragility fractures, includes whether there's a family history of your mum having a hip fracture. If you're too thin, then that increases the risk. It's one of those rare things where you can be too thin. And then if you smoke at all, or if you drink more than 3 units of alcohol a week, then those are risk factors as well. And there's various other things like inflammatory arthritis is also an independent risk factor because it stimulates the osteoclasts which break down bone, and that loses bone. So if you want to know your individual risk of osteoporotic fracture, there's an online tool which is called FRAX, F-R-A-X. And if you want to look that up on Google afterwards, then you can actually get the little tool, and there's enough instructions on there for you to put in your risk factors and calculate your own risk score. And then there's a little link, a button, which takes you through to the National Osteoporosis Guideline Group. Now, if you've had a bone density scan as well, there's the opportunity to put in that T-score result, and that's the total hip T-score. And that will give you a risk, whether you're in the green zone, whether you don't need treatment for osteoporosis, or whether you're in the red zone. And if you haven't put in the bone density score, or don't need one, it'll tell you if you're in the orange zone and would benefit from having a bone density scan. That allows you to know your own risk. And knowledge is power. Because particularly if you've had a broken bone or there's things in the family, or if you've taken steroid tablets for a while, then you want to have that information. And it's one of the things that you have control over. Okay? So that's something I'd encourage people to look at if they're interested. In this situation, our core treatment for osteoarthritis, and I was on the NICE guidelines where we reviewed the evidence, we decided the treatment guidelines. The 3 core things are, firstly, weight loss if you're overweight, because there's more load. More load and fatty tissue also drives inflammation, which is important in osteoarthritis. So it's try and get your ideal weight range, which is between a body mass index of 20 and 25 kilograms per meter squared. Again, this is easy to calculate online with a little online calculator if you want to. You don't know your own numbers. You just need your height and convert your weight into kilograms. And then secondly, strengthening and aerobic exercise, both of which have numerous controlled trials showing that they help pain in the knee and hip. And then thirdly, education. And we've got a very good charity which provides some of our funding called Arthritis Research UK. But have you heard of Versus Arthritis? Yeah? So that's the new name of Arthritis Research UK. And collaboratively with the Medical Research Council, which is the event that we're speaking at, they fund our Centre for Integrated Musculoskeletal Research into Musculoskeletal Aging that Professor Lockman's going to explain to you. So those are the 3 core treatments, and the other stuff comes after that. So if you've got osteoarthritis, think weight, think exercise, think online information and download the leaflet from Versus Arthritis. And if you've got residual pain after looking at those things, then you might be in a position of seeking healthcare. And there's a researcher in London called Mike Hurley who's developed a thing called the Escape Knee Pain Group. And they did lots of big studies which showed that that was effective. Again, it's an efficient, effective way of treating people with knee osteoarthritis. And that's increasingly available across the country.
Can I ask a question? Is osteoarthritis just part of the aging process?
Well, that's a really good question.
To most. There's no
Shall I
way
repeat that
avoid-
question? The question was, is osteoarthritis just a part of the aging process? We certainly used to think that, but osteoarthritis is my research interest, and we don't necessarily think that now. It turns out that although osteoarthritis gets much more common with age, it turns out that it's a disease where episodes of inflammation are important, and biomechanical stress is important.
Injury, I suppose.
Injury, so if you injure yourself, if you have a fracture through the joint line, you're going to get early osteoarthritis. If you rupture a ligament in the knee, or if you have a shallow cut-up for the hip when you're born, you're very, very likely to get early osteoarthritis. So the biomechanics are really important. But the key is that that is something which feeds in to the risk, and somebody who lives well and keeps the weight down and exercises regularly and doesn't have injuries isn't necessarily going to develop osteoarthritis. And even the people who get pain and have osteoarthritis clinically don't universally progress. It's not like if you start getting knee pain, everybody like that goes on to have a knee replacement, okay? So understanding the myths are really important. And one of the studies we did up in Northumberland was we looked at the people who were over the age of 85, and this was inspired really by work that we're doing in Newcastle, a cohort of people who were hitting the age of 85. But when we looked at people who were 85 to 97 and x-rayed every joint, we found they didn't have osteoarthritis everywhere, and they didn't all have pain. Whereas if it was just age-related, the older you get, the more universal it would become, and that's not the case. So you are in control of this, and there are things that we can do as we understand it more. I would talk about osteoarthritis all day, and that would upset my colleagues and bore you all silly, so I'm going to move on if that's all right. This is a good one. Diet and health. Low fat or low carb, paleo or Mediterranean, and more. The online debate rages, passion on both sides. How are we to know? Right. Who's ever been on a diet? I think everybody at some time. And there are no simple answers, because actually lots of different diets can establish weight loss. But I think this actually speaks to a bigger question about how can we change our behaviour effectively. And given that we're in a mock group consultation, I'm going to share with you some data which I heard presented in the recent meeting in New Zealand, where our colleagues in Australia, Gary Egger and John Stevens, had done a prolonged study of what they call programmed shared medical appointments, which is a 4-month intervention with regular groups to try and achieve weight loss. And that's largely based on the low-carb diet. Okay? And what they saw was very different to what you usually see in the types of studies. Essentially, I don't know, if we're thinking of headlines, there were lots of headlines about 3 months ago about the DIRECT study. Did anybody read about that? This was the powders, and the study, a team led by Roy Taylor in Newcastle, had shown impressive weight loss by meal replacements, yeah? And what they'd seen was was impressive, and just as impressive as the weight loss you saw in the diabetic prevention study, the program that Jonathan Valaggia has rolled out across the UK, that was led groups of health trainers. And this intervention in Australia, at 4 months, they'd established good weight loss, about the same as the direct study. But what was different about this study was they then stopped the groups and they followed them and looked again at followed them up to 12 months. And what you typically see in a diet intervention study is you see that the effect is lost and people gain weight again. Okay? Is this sounding familiar for people who've tried to lose weight in groups? Okay. So what was different about this very structured group, the program shared medical appointment, was that weight loss was sustained and continued to increase once the intervention had finished. And we had an interesting discussion at the meeting because Gary Egger felt this was because their doctors were holding these meetings, and it was the very powerful effect of the professional that was having the influence. And I told him, that's almost certainly rubbish. Okay? We should do further work to explore it. What I've seen in groups is it's the relationships and it's the understanding of the problem that's shared and the mutual support network that is formed within the groups. To the extent that our groups in ANIC, one of the people attending groups has started their own patient support group because they were so inspired by the model. So that's what happens, I see in practice, and that's why I believe this influence was sustained. And let me share one more story from the meeting, because there was a Maori lady who come in, who lives on the edge of Auckland, and she gave a very powerful presentation. And this is how important patients can be sometimes in telling their stories. She invited 2 volunteers to come up on the stage, and she put her arms around them. And she said, "Thank you for coming up on stage. This is the size that I used to be." She was 240 kilograms, and she showed some photos of her. And she had surgery on her stomach, which had failed to establish any weight loss. But she changed to a low-carb diet, okay, which was much closer to the original Maori diet. They eat a thing called boil-up, where they have fatty meats. It's all boiled up with lots of fresh vegetables, and so it's quite a fatty meal that fills you up. But she cut out all the potatoes, all the starch from the modern diet, and stopped eating takeaways and everything. And I can tell you, her husband was not pleased, because he didn't get a choice. He was told, this is what you're doing as well. And one of the things about the Maori culture is that they have this great belief in the extended family. It's what they call whānau. So she wasn't just having an impact on herself, she was having a big impact on her extended family of at least kind of 12 to 18 people. And she started losing weight, and she just carried on losing weight. And now she's around 75 kilograms. So she's lost 2/3 of her weight. From somebody who was at that extreme of being overweight, to lose that type of weight is exceptional and inspiring. And yet, at that meeting, other stories of people adopting low-fat or low-carb rather, or keto diets. There was a community who lived on the border of one of the lakes, Lake Tahoe, of over 400 people who had done the same thing, and their weight loss was measured in tons, not in kilograms.
Can I
Course.
comment, please?
Yeah.
I heard us saying quite some time ago, when you diet, you gain fat, you get fatter. And the reason is that when you diet, you're losing fat and muscle. And then when you put weight back on again, the muscle doesn't return, but fat does.
Okay.
So dieting makes you fatter.
So-
So I suggest if this female you're talking about, if she didn't exercise as well, which must be a very important part, she would be very medically dangerous, I think.
Well, it's a difficult one, and obviously what she was doing was having a balanced diet. So the question was really, when you lose weight, your comment was actually you lose muscle as well as fat. The answer is not necessarily, but it is important that you exercise. And if you look at effective weight loss interventions, they almost all should include exercise as well as weight. Because to live healthily, we need a certain amount of exercise. And the goal is naturally for us to get 150 minutes of moderate exercise. That's the type of exercise makes you a bit sweaty, makes your pulse race a little bit. I could ask, I often ask my patients how many people do that amount of exercise, and it's less than 5%. Okay? But it is possible to do that exercise. And I tell the story not because I think that's the only way of establishing weight loss, although it was a very powerful personal story, I tell the story because it shows that it's possible. And actually, if you're going to make a change for yourself and change your life for the better, then you're best to choose one change. And to say, this is what I'm doing, and share it with your extended family, as she did. And of course, it took a couple of days for her husband to come back from his sulk and say, yeah, I do want to grow up and see our grandkids, yeah, and live a good life together. Because they've been married already for 39 years when she came up with this idea.
Could I ask a follow-up question?
Yes.
The diet question was mine, and why I asked it because even within the NHS, as you will well know,
Yeah.
there is completely contradictory information. You can
There
get
is.
diet sheets
Yeah.
that tell you to go low fat, then you go onto the internet and it's the low carb. So that, I think, needs sorting out. I think there's obviously division on
Agreed.
that. But my question was, that about that bit of research you mentioned, you said that in the low carb experiment, you thought the reason it still had efficacy for these people 12 months later,
Yeah.
was the group still running for that 12 months?
No, the group weren't meeting, but they were from the same community. So they had a support network.
So they had a support network. So it's that continuing
Yeah.
support network
Yeah.
which you think is the...
And it's quite interesting because I rang one of my GP colleagues in ANIC today to ask a question about a specific patient. We were talking about how you can provide support for people. And she pointed out that now that social care is being looked after in primary care, they're setting up things like a walking group, a knitting group,
Yes.
an art group. So actually, it is happening, but we're not measuring it properly. We don't know quite the extent of it. I agree about the guidelines and the inconsistency, but I would say that we've got the British Society for Lifestyle Medicine meeting in Cardiff this weekend, and there you hear it very clearly expressed that actually big food industry has too much influence on policy, and very often people are employed to lobby government directly, and it's often not declared, and they have a bit too much influence. And the examples often shared are, you know, you've got something which is green and recommended, and it'll be a cereal that still has, 20 grams of sugar. Yeah? So it's all about setting the right targets and understanding what is good care, and then individualising and finding what works for you. And I agree, there is some work to be done, but I think there's increasingly a consensus about what is right. We just haven't got it to the level of policy. I'm probably going to attract a bit of controversy about that, but I'm happy to have that debate. Okay, so thanks for your questions, but really good. Can you guys let me know when I'm talking too long? We need to move on. Is that all right? I just want to answer as many of the attendees' questions as possible. So this is an interesting one. My elderly mother-in-law has lost a lot of weight recently. There seems to be no underlying health issues, but she's really struggling to regain the weight. So what should we do? What should she do? So that's an interesting one, because as we've already said, there is an ideal weight. And if the weight loss is bringing her into the ideal range, I wouldn't worry too much, okay? But with weight loss, there are a few things that raise a red flag to us. We even call them red flags. And the red flags would be if somebody's losing weight, they've got a change of bowel habit, or they've noticed if it's a woman, if they notice any breast lumps, if it's a man, if they've noticed any lumps in their testes, or if there's any bleeding or mucus when it passes through, yeah? Or if they notice lumps and bumps elsewhere, or if you're getting nasty sweats at night, yeah? Or very bad pain in the back or elsewhere at night pain, then you should consult your doctor and go to the surgeon and find out whether there's an underlying problem. Or not all weight loss is bad, and sometimes it's a good thing. So I'll give you an example. In my clinic, sometimes people take tablets that make them feel better, and arthritis is very well controlled, and yet it blunts their appetite. And so they start losing weight. And I tell them, brilliant, that's not a side effect, that's a side benefit. Okay? As long as you don't feel dreadful. And it's really important that we understand that as individuals, there's a range of experience that we all have. And as long as we're in the right range and there aren't any red flags, and your weight is coming towards or is in the ideal range, then there needn't be anything to worry about. Okay? There's usually a reason when people are losing weight, and it often relates to just not feeling hungry for some reason. Sometimes it's because they're depressed, and they're not actually eating properly. Yeah? So I think if it's sustained, or if there's any red flags, then you should consult about help, but otherwise, enjoy the weight loss. I'm going to pass this one over to Tanya. It's a question about quinine. If you're happy to say that.
We're going to do that one.
Okay. Yeah, so quinine, I've taken quinine for leg cramps for 5 years. I'm trying to get rid of the... All of a sudden they've been stopped. I was advised to drink Indian tonic water, which helped a lot, but the side effects were embarrassing. I'm not going to talk about the side effects, unless you really want to. Now on iron tablets, again, which have side effects, iron tablets typically constipate you. Can you recommend anything better? So that's quite fascinating. So quinine is often used for cramps. And very often in our group clinics, we talk about cramps, and it's a very common experience. Perhaps 30–40% of people suffer from cramps. And it's more common when you've done unaccustomed exercise, and it's more common when you've got changes in your fluid balance or your electrolytes, same starts with a water tablet. But quinine has never really had any controlled trial showing it works. So when you stop a tablet, which is not supported by the evidence, you could argue that's quite a good thing in terms of not wasting the money for the NHS. And obviously the reason that they advised you to take tonic water is tonic water contains some quinine. It's a little bit of quinine. That's why it tastes so bitter. So the example I give, we give a tablet called hydroxychloroquine to our patients, and I say it's very bitter, like tonic water. So you want to swallow the tablet quickly. But actually the amount of quinine in tonic water is probably not enough to make a difference to quinine. And we already know there isn't actually controlled trials evidence that shows that quinine really works for cramps anyway. So if cramps are a big issue, think about the exercise you're taking, think about your fluid balance, and one of the things you can all do is do more regular exercise, because then the muscles get stronger and they're less prone to the cramp that comes with unaccustomed exercise. So it may seem a bit counterintuitive, and your immediate response might be to say, oh, I've had cramp, I better not do that form of exercise again. But I would say the opposite. The health benefits of exercise are so great that we should all be trying to fit the exercise into our day. Whether or not it's walking the dog, and one of the tips is, how many people here have got a smartphone? As opposed to a stupid one? Yeah, okay, most, 90%. It's interesting, the scientists are not answering that question. They're just assuming that I know they've got smartphones. Although the other thing is, scientists are smart, they don't like their phone to be smart. So, you see my use of humour there. Ironic. So, one of the things about smartphones is they know where they are and they know how many times you're stepping. So you can switch on the function that tells you how many steps you've had. Or if you've got a Fitbit or other smartwatch, then you can measure how much exercise you're doing. And the thing is, just once you're looking at it, and quite a few of my patients came in and say, oh, I'm doing 7,000 steps a day. And I say, well, that's great. Why don't you push it up and try and get to 7,500 next week, and then 8,000 the next. So you've got to monitor a way of already seeing how much exercise you're doing. But the key thing with exercise is to do the things you love. If it's the dance class, if it's going out on the golf course, if it's swimming with your friends, if it's got a social element, and we've already talked quite a lot about groups, then if you're doing it regularly, then that embeds you, because they'll be inviting you out. And it's like the walking group at practice that I was talking about. Does that make sense? So I think there's reason to try and get off quinine unless you absolutely need it. And if there's a big issue and you're really missing it, you can always ask. So, this next question is about uncemented hip replacements. And I'm going to pass it on to Tony because he's in another life and orthopedics. So the question was, I have an uncemented hip replacement, but I've never really understood why some people have cemented and some uncemented. My other hip needs replacing. So will that have to be uncemented or doesn't it?
So nice to meet you all. My name is Tony. I'm an academic orthopedic surgeon. I'll come and speak about my research a bit later, but I will handle this question. So thank you very much for the question. So a lot of things in surgery tend to go in vogues, which sounds strange, but it's true. So sometimes somebody says, well, this looks like a really interesting thing. For example, we'll not put cement in. But then by the time we know the answers about that, it takes 20 years. The patients get the hip replacement, which we know is safe, but we don't necessarily know the long term how good it is. So there was a vogue a few years ago for uncemented hip replacements, so a lot of people have them. We know that they're generally safe, but there are advantages and disadvantages in both. The main advantage of using cement is that once you put the hip replacement into the hip, it holds very strongly immediately. So the uncemented replacement relies on friction to stop the hip moving, whereas the cemented replacement allows the hip to be immediately usable. So most people who have a cemented hip replacement will be able to get up the first day after their operation. The hip should theoretically stay in place longer and should be usable immediately. So that's the main benefits as we get people up earlier with cemented hip replacement. Most surgeons in the northeast nowadays will be using cemented hip replacements on the whole, and that's because we have a bit of evidence now down the line that they are a bit better, they last a bit longer. The main issue used to be in the past that people worried that the cement could very rarely cause problems during the operation. It can go into little blood vessels and cause really major problems, but over the years people have developed techniques to avoid that, and that very rarely happens nowadays. So personally, my experience in the northeast is that most surgeons, it is surgeon preference, but most surgeons will be using cemented total hip replacements, and they're probably the gold standard.
Great.
My question, so when I have to have the other one done, it doesn't matter?
It depends on some of the surgeons. Some of the surgeons will vary. Some of them will still be uncemented.
But you can have one of each?
Yeah, you can have one of each.
That's
So,
what you know then.
as long as the other one's fine and not causing any problems, it doesn't matter what this one is. I would expect your surgeon will probably do a cemented hip replacement because we think they're a bit better now.
Right.
But yours seems to have, is it serving you well so far?
Sorry, yeah, great.
So we know they work.
There.
Yeah, yeah.
Totally unaware.
Do people mind me asking, how many people have had a hip or a knee replacement? Okay, so there's quite a few. So how many people had to fill out the paperwork because they were put into the National Joint Registry?
Sorry.
The National Joint Registry. So when you have your hip replacement nowadays, and it's been increasing, so there are a few people as well. That's one of, so Tony's alluded to why we know that something is better.
Right.
But over the past decade, we've gone from really not being very good at routinely collecting data to being very, very good, one of the leading countries in the world for collecting routine clinical data on joint replacement surgery. And that has been transformed. Okay. So for example, everybody's read in the headlines about Andy Murray getting back to tennis. Yeah?
Yes.
So he's had a hip resurfacing procedure. And that procedure, we thought a few years ago, was going to be better, especially for younger people. And it was getting very widespread with lots of different implants being used for it. And the National Joint Registry data showed very clearly that that was wrong, that they failed sooner, that they had higher complication rates. And this wasn't an operation that we should be experimenting on people. So that's quite powerful. And I did my PhD in Manchester, where there was a chap called John Charney. Have you heard of John Charney? John Charney was the very first surgeon to do hip replacement operations. And do you know what happened to his first 200 hip replacements? They all failed within the first 2 years. And then he had to revise them, obviously, because the plastic was too soft. And they put in a hardest plastic, and he slightly left Manchester Royal Infirmary and turned up at another orthopedic hospital nearby. And now, hip replacement is widely regarded as the most successful operation there is. But nowadays, we have a different level of science, and if he was doing that work now, he probably would have done a small randomized trial where he put some people under the knife so that they didn't know whether or not they'd had a hip replacement and some people. But obviously it's too late for us to go back to that stage now, but the National Registry data is absolutely transformative and it's critical. When you look at that data, and I would strongly encourage people who have either had a hip replacement or are looking for one, to potentially look at their own data if they're interested. Because there is published data, it's anonymised, so it won't be clear what your surgeon is achieving, but it will show you what your type of replacement does. And if when you go to your consultation with your orthopedic surgeon, if you're saying, well, okay, so why are we using a cemented hip? And you know, if you have that discussion about what they're using, they'll be happy to have that discussion. They might swear.
So I'll just like to through those points. So the first thing to say is that the joint registry has been transformative. So every joint is now mandatorily entered into that registry, so every person who has a new operation will, unless they refuse to consent, be put into that registry. And that meant that a few years ago we picked up a problem as well with metal and metal hip replacements, which people might have heard about metal and metal hip replacements, but there was big issues with those. And we only picked that up because somebody's externally auditing all the operations. The second thing to say is, as Dr. Burrell said, looking at the hip replacements, incredibly good operations. So I was in America earlier this year, saw some data from over there. And the operation that improves patients' lives the most is a total hip replacement, with any operation. So from pre-op to post-operatively, it's the most successful operation in big data sets, in not just orthopedic surgery. So it's a very, very good operation, which is probably why you've had a good result.
And the other big change, which is being flagged on the registry as well, is that people aren't staying in hospital very long.
No, just a couple of days.
Yeah. So actually, you know, 2 days is relatively long now. Some people are going home the same day. And the advantage of that is we're not just trying to save money on the hospital bed, although that's a part of it. It's safer. There's a lower risk of infection. There's a lower risk of clots. People do better when they're in hospital when they mobilise quickly. So it's another reason to try.
I'm sure you'll know as well that Professor Michael Reed's been doing a lot of day case replacement surgery in the Northumbria Healthcare Trust with excellent results, really good results on the same day. Come in the morning, have your operation done in the afternoon, after seeing the physiotherapist.
Would that be cemented? Because I was
Yes.
on crutches for 6 weeks.
Exactly. So that's the benefit of scientific replacement is once it's in, you're up. So if you're going to do day case surgery like that, you'd have to use cement replacement, which is why we do it.
Okay.
Thank you.
And let's do one final question, actually. And I'm hoping Tanya might answer this one. I'm giving CBD oil to my dog. Did we say it was for dog healthcare? It seems to be working as she is less stiff. Could I use it for my own arthritis? Want to answer that one?
Hi everyone, I'm Tanya, I'm a pharmacist and I do work in group clinics quite a lot. Hopefully I can answer this question. So CBD oil is related to cannabis, it's cannabidiol, and there's a lot of interest in it at the moment because there has been some studies that have shown that it's quite useful in helping treat pain, especially with arthritis, and also to help with inflammation. But the problem is that it's quite a new product and there's not a lot of research being done in human studies. So a lot of the evidence is coming from animal studies which has shown that they are effective, that it can help to relieve pain and inflammation. But in human studies, there's only been really limited small-scale studies. I think that's quite important when we're thinking about whether a treatment is safe or not, because we need really good, well-designed studies to be able to answer that question. So given it for long periods of time where we can see how the drug actually works over longer periods of time, and whether it's not a placebo effect either, where you take something because you think it's going to work and then it doesn't actually, when you do it in a scientific way. And as I say, the human studies that have been done have shown some promise and have shown that the cannabis oil is quite helpful. But because the studies are really small scale, we can't actually say for certain whether that is a true effect or not. I think what's quite important to mention is that cannabis oil is not like having a cannabis that is illegal, if you know what I mean. Because cannabis oil is only cannabidiol, it's one of the types of cannabis that doesn't have this kind of hallucinogenic effect. The active part of cannabis that is called THC, tetrahydrocannabidiol, and that's the active bit that can cause a lot of side effects. So with cannabis oil itself, if you're just having that pure CBD, you don't tend to get many side effects. The side effects that we've seen in the studies have been quite mild. A bit of problems sleeping, insomnia, headaches, dizziness, and so on, but not the same effects that you would get with the more illegal drug that has been used in other places. Currently, cannabis oil is licensed for a type of epilepsy. It's not actually licensed in the UK at the moment for arthritis, and only certain doctors can prescribe it. So a lot of our patients actually ask us about this because they've heard so much about it and they want to try it. But it's not something that can be prescribed widely at the moment. I'm sure that's what you've been asked about, haven't you?
We've got a follow-up question.
Yes, thank
Do you
you.
want to use the mic?
Yeah, I was prescribed Sativex for about 3 years for neuropathic pain, and the hallucinogenic effects certainly were difficult to get used to. Dizziness, yeah, it did, I think, have some effect on the pain, but I stopped getting it because of the cost factor now doing ketamine for neuropathic pain. So, you know, I can talk from my own experience that it does have an effect.
Yeah.
But it was partly because of the expense, partly because I was, getting, I wouldn't say hooked on it, but the hallucinogenic effects were quite interesting.
That's interesting to hear, yeah.
So what, the CBD oil that's sold in the likes of Holland and Barrett, is that just a weaker form?
Yeah, I mean,
Is it worth trying? Is this?
well, you could try it. As I say, the side effects that we've seen so far are quite minimal, and it doesn't contain, the one that you can buy in the shops doesn't contain the kind of hallucinogenic component, the THC. So the side effects would be minimal, but what I would say, and this goes for any kind of herbal remedy or any kind of unproven medication, is that even though these are unproven or they're herbal, so you think they're safer, they're not necessarily safer, and they can interact with other medications that you might be taking. And an example of that, it's quite weird really, because the medication, the CBD, it's licensed for epilepsy, but actually the medication interacts with a lot of anti-epileptic medications. So many of those medications affect the liver, and they can be they can alter the levels of other drugs. So what I would say is, if you're not taking any other medication and you have no kind of other conditions that might be affected by it, then by all means give it a try. But what I would say is, if you're not sure, check with your pharmacist or your nurse, your doctor, before you start trying anything herbal, you know. Things like St. John's wort, for example. People use that for depression. And the problem is that because it's a food supplement, it's not necessarily a medication that's been trialled in the same way that other medications are. That interacts and can cause all sorts of really bad interactions with other medications. And it can reduce the levels of other drugs. So if you're on a medication for epilepsy, it could actually get rid of the drug you really need. So I would just say, you know, always check before you want to try anything new.
Because the CBD oil, the marketing is pretty impressive. You know, the leaflets you get in the likes of, that's all I've got to now is take the leaflet. The leaflet is very impressive, you know, it makes you want to go out and buy it. But,
I think overall, a lot of people are very interested in complementary and alternative medicines. And Versus Arthritis has a very good leaflet that you can download, looking at the complementary and alternative treatments and the evidence for them for osteoarthritis, for rheumatoid arthritis, and for fibromyalgia, which are very common conditions that affect a lot of people. So please do download that if you want to have a look and look at the evidence. Right, so I think we've answered most of the questions. And what I want to do now is to kind of transition on to hearing from our scientists. Obviously, the group consultations provide quite a unique venue for a two-way conversation about research. In the past, we've certainly used it to present research ideas to members of the public and patients to see what they think about the research. That's important because it anchors the research in real-life experience and helps us get opinions for that. Sometimes there'll be headlines where you have questions of, so for instance, a couple of years ago there was a new box that they were trialling in Amsterdam, and there was a box that stimulated your vagus nerve, and the patients had brought in a clipping. It's always the Daily Mail. It's always the Daily Mail. From the Daily Mail, and saying, well, can we get one of these? And so we talked about the evidence and that it was an uncontrolled trial, and that actually before you start adopting something more widely, you do, as Anya's highlighted, you want bigger trials and you want properly controlled trials. We can show you whether the effect is real. But the other thing is that we also run clinical trials. So we're just about to start a trial in Northumbria at North Tyneside for bracing in knee osteoarthritis. So if anybody's got knee osteoarthritis and they're very keen to be involved in the trial, please let me know afterwards, because we are starting a trial hopefully next month called PropOA, and that's funded by the National Institute for Health Research. So there is an opportunity when we're treating people to give you the best care we have, and very often we'll say, these are the things that are core that we know work. Above that, if you've still got pain and problems, please do avail yourself of other things that you want to try. And sometimes you'll do an N of 1 trial where you see whether it works for you. There isn't good evidence that it works. But then, if we can give you access to the latest clinical trials to participate and contribute towards answering the important clinical questions, then that gives you and other people choices, healthcare choices. What we're going to mainly do today is give an overview of research that's happening in Newcastle. And so without further ado, I'm going to hand you over to Professor John Loughlin, who's going to explain what SEMA is, what he does.
Thanks, Fraser. Just to start, I'm drug-free at the moment.
You're drug-free? How long?
I believe so, yeah.
How long?
8 hours?
8
hours, something like that. But legal.
Nice warm chair.
Yeah. Is that an evidence? Right, okay, so my name's Professor John Loughlin. I work at Newcastle University. I'm based in the Institute of Genetic Medicine, which is down at the Centre for Life, the Central Station. So I'm going to be talking to you about, introducing to you one of the MRC and versus arthritis funded centres that's based in Newcastle. And it's called SEMA, which is the Centre for Integrated Research into Musculoskeletal Aging. It's a collaboration between Newcastle University and also the University in Liverpool and Sheffield. And we came together because of the different expertise that the three universities have in the musculoskeletal system. So in Newcastle, we're particularly strong in cartilage, so one of the tissues that's involved in the articulating joint, and arthritis, so that's our core strength in the musculoskeletal field. Liverpool has a particular strength in sarcopenia, which is the loss of muscle mass, and Sheffield has a particular strength in the bone, and osteoporosis. And perhaps the study that Fraser mentioned earlier was actually developed in Sheffield and is applied by those. So when we came together as three universities, we wanted to work on the diseases of articulating joints, and we decided to come together because of those shared expertise. And the MRC and versus arthritis have provided us with several £1 million worth of funding. And we use that funding to do a variety of different things. So some of it is used to directly employ people in Newcastle, Liverpool and Sheffield who facilitate the research. We also have funding for students. So we have Ellie, for example, is a student that is funded through that. So she's on an NRES PhD program. So that means that she does a master's degree first and is then going to move on to do a PhD. And all of that is funded through SEMA, and she'll be talking about that later. And then we have other funding as well. So Tony's received some funds to do some work in my lab as part of his academic clinical fellowship. And he'll be talking about some of the research that he does. So Tony's an orthopedic surgeon, but he has a strong interest in science as well. Then Ellie is a postdoctoral scientist who works in my group. And Ellie is in receipt of funding indirectly through some of the other support staff that we have through SEMA. So people that can help her do analysis, put tissue specimens from surgery and so on. And then Tanya is somebody that's going to be talking about her research as well. So the idea is that you get a flavour of the different types of research that's underway in SEMA, with a particular focus on that that's happening in Newcastle. And if you have any questions of me or any questions of the others, they'll be around afterwards and what have you, and can deal with that for you. So without further ado, I think I'll move on to Ellie.
It's neatly done, but before we do that, is there anybody who's got any questions for John? Want to know more? He's a figurehead, he's a leader. He used to work in the lab and now he directs other people who do that.
I do. I actually go around the
When did you last get your hands dirty?
this morning.
Okay, well, impressive, impressive. I withdraw my comment.
That's it.
I'm trying to set the tone so we make it clear he doesn't mind being challenged.
No, I don't mind. I don't mind at all. I mean, would you like me to give you more of a flavour of the type of research that we do? Maybe it's before they begin. Perhaps I can just say that my actual area of expertise is genetics, human genetics, and really trying to understand why people develop osteoarthritis from a genetics perspective. So it comes back to the question you asked earlier. Is it almost an inevitable consequence of aging? And it transpires that, as Fraser touched on, that's not necessarily the case. What we seem to find is that there's good evidence that people will inherit risk of osteoarthritis from their parents. So there's a genetic transmittance of the disease. But it's a particularly complex form of transmittance. So when you look at families, it doesn't track in the families in a very clear way. It's quite diffuse as such. And the reason for that is that there are lots of genetic risk factors in the human genome that contribute to the disease. So we've been involved in mapping some of those particular risk factors. I'm actually treading on Eddie's story here. But we're also doing functional analysis as well. And the way that we do that is we collect very large cohorts of people that have the disease, and we compare their genomes to people that do not have the disease. So What that means is you look at their DNA architecture and you look for subtle variations between the individuals, and often those subtle variations are in of themselves causal. And then once you know that you've got a particular DNA change that's a risk factor, you can then try and work out what it's actually doing. And we do lots of that work as well in the lab. We do a lot of cell biology, molecular biology, molecular genetics. And we also use a lot of specimens from people that have undergone joint replacement surgery. So when people have had their joints replaced, if they donate it to the lab, we can take that material and we can actually analyse the DNA in the cells and work out what's going wrong in osteoarthritis. Actually, it's a good point. You told me to do this. So what I'm kind of describing to you is all what we call, it's a slightly derogatory term, it's called basic research. But to us, it's discovery research. So we're trying to understand why something happens.
Do you see any difference in nationalities, like the West and the East? Is there a difference?
You do. You see some really interesting differences. So often when you look at risk factors at the DNA level in people of European descent, they're normally quite different to those of individuals from Asia. And those are the kind of two largest ethnic groups that have been analysed in that way. And osteoarthritis is really interesting to a certain degree, because what we think's actually happened is that a lot of the genes that are causing osteoarthritis are responsible for how your skeleton forms in the first place. And the genes are, in a sense, positive for a healthy skeleton, but that has a detrimental effect as you age. But in an evolutionary concept, it didn't really matter. So when those genes were doing what they're doing, tens of thousands, hundreds of thousands of years ago, they were being selected for a good skeleton. And people wouldn't have survived into old age, so their detrimental effects wouldn't have been apparent. But now that we're an aging population, those detrimental effects are emerging. So it's a kind of consequence of having a very good skeleton, but it does seem to impact upon the health of the skeleton as we age. And we're starting to look at a lot of these genes and a lot of their effects in material from younger individuals, and we can see the effects happening during skeletogenesis, so during the formation of the skeleton. So we think that's what's actually happening in osteoarthritis. So in a way, it's a disease that is a consequence of us living longer, but it does have a positive effect early on in life. It enables us to form a good skeleton. At least that's our interpretation of the data so far. So one of the things that we want to do, obviously, when you start to discover things about diseases like osteoarthritis, you're always thinking about what can you do about it. So can this data actually help you to think of new treatments and new therapies? And there are ways and means of actually subtly altering people's genomes, but not in the germline, so not the way that's transmitted to offspring. You could actually do it in people's cells as adults, and then think about making tissue more resilient, so it's less likely to succumb to the disease itself. But that's the kind of translational, kind of therapeutic component. We're not doing that at the moment. We're very much in the lab thinking about doing it. And again, I suspect Tony will touch on this. As an orthopedic surgeon, Tony would be very interested if he could develop techniques for doing that in surgery. So instead of necessarily having to replace the whole of a joint, it may be possible just to replace some of the damaged tissue, but replace it with tissue that's more resilient than the tissue that's currently there. And we can perhaps potentially do that using the genetic data that we've developed. So, that's right. Is that okay?
Thanks very much, Sean. You did do fantastic.
Did I do okay? Thank you.
Where does wear and tear sit in the context?
No, go on, praise.
Shall I answer that one? Wear and tear is an old model that we need to let go of. Disagree. So the idea of wear and tear, if it was true that osteoarthritis was an inevitable consequence, it would be quite a useful model. And if that was the case, then the more exercise we did, the more the joints would wear out and the worse we'd be. That's manifestly not the case. Because if we do exercise and we stay fit, we aren't necessarily at risk. And although there was lots of data suggesting that elite athletes quite often get osteoarthritis, when you look at the detail, it's because they get injuries.
It's trauma.
It's trauma.
Yes.
It's trauma. So now increasingly we're letting go of wear and tear. And the next time that your GP or anybody else uses the phrase, you can say, I don't know, Dr. Brill told me we should be thinking about tear, flare, and repair. So tear, because as we mentioned, tears to the ligaments the supporting structures around the joint that are very important. Flare, because there are episodes of inflammation, and that inflammation can sometimes be in the lining of the knee, or it can be sometimes in the tissues around the knee, or even underneath the bone. You get subchondral inflammation that you only see when you do an MRI scan. But the pain is incredibly strongly associated with those episodes of inflammation and compartment-specific progression. And then finally, repair, because repair is what happens. The body's good at repairing. And if we can tweak things to optimize the chances of the body repairing, that means that we do far less harm. So rather than the negative idea of wear and tear, and gosh, I better not overwear my joints out, if we instead say, actually, tear, flare, and repair, once we've got this problem, we need to exercise, we need the muscles, we need the strength. Otherwise, we won't improve the pain. Our body will repair over time. It's a much more positive model for us to use.
Is it progressive once it's happened?
Is it progressive?
Yeah.
Not universally. So there are some things. So I can allude a little bit because John mentioned it, but I'll flag it now. So SEMA have actually given us a grant to extend Tanya's work looking at microRNA profiles in a big American study called the Osteoarthritis Initiative. And that's a massive study where they've taken people with knee osteoarthritis and followed them over time. And they've done lots of scans of the knees, and that's given us a much better understanding of what are the things which help to predict progression. And it turns out that people classify as either fast cartilage progressors, who are just like that, and they do badly, and there are slow cartilage progressors who do much better and don't usually progress. And then when you base the research around that, you can then look at the predictors, the markers, which are going to tell us about progression. So the simple answer is we don't all progress unless you've got worrying features and your doctor tells you that it's a problem. Then don't believe. In particular, don't believe the story that's often told. Is that I've seen lots of people being told, "Oh, you've done this, so you're definitely going to need a knee or a hip replacement." We simply didn't have the data 20, 30 years ago to make that assumption. So if you were told that then, it's probably wrong. Now we do have some idea of what factors are important. And loss of alignment is incredibly important. And overweight is much more important if you've got loss of alignment of a joint. And then if you've got the hip involved, if you've got the pattern where the hip is coming out and is splaying out rather than moving in, then you do much worse than if you're going the opposite direction. So there are a few factors that we know are important, but increasingly we're trying to put together the best science, the pure science, with the big observational studies that allow us to examine the influence of the molecule against the person who has a genetic background.
I have one knee replacement which was very successful on it.
Good.
But from time to time I get pain there and there. Would that be where the ligaments, tendons are rejoined after the replacement?
I can.
Because the knee
Yeah, well, what I'm going to do is I'm going to hand over at this stage to Tony, who's our next speaker, and oh gosh, I'm looking wrong.
Tony Grant.
Okay, so let Tony answer that.
So in brief, something called anterior knee pain at the front of the knee. So this is the anterior part of the knee, one of the most common problems with knee replacement. We still don't really understand why it happens. Professor Dean here is doing research trying to work out why it happens. It's when I spoke about the score for how good an operation is that I saw presented in the States. The total hip replacement, absolutely fantastic. The total knee replacement, nowhere near as good. We still don't really understand why patients get this. So most people get a good result, but up to 33% of people have this problem with pain at the front of the knee, and we're still not on top of it. We've known about it for years. There's a lot of people trying to do research in the Northeast and globally looking at this problem, but they're not quite there yet. I know there's people in this region looking at that problem. So
what are you giving now for post-operative pain? Because I refused to go back in 6 weeks after this one to have the other one done because the post-operative pain was just not controlled. It's all their fault. The pharmacists wouldn't allow me to go home on OxyContin, believe it or not, because the worries about drug abuse. And I find that astonishing because I know people that have Oromorph liquid and they don't bother measuring it, they swig it from the bottle. So, I have to say that paracetamol and codeine phosphate is like taking feeding an elephant with strawberries, it was just...
Okay, interesting what you say about paracetamol, because now there's overwhelming evidence that paracetamol is ineffective.
Totally ineffective.
Okay, so it's interesting that's your experience.
Totally ineffective.
But perhaps another take-home message today might be, how many people have taken paracetamol in the last month? Well, the bad news is it doesn't work. The even worse news is it's actually a mild anti-inflammatory. So at the moment, if you're told by your doctor to take paracetamol as well as ibuprofen,
Yes, together.
we have very good evidence. Firstly, it doesn't work well together, but they have more toxicity when you use them together. Because it turns out paracetamol, there's now overwhelming evidence, several meta-analyses published in the high-impact journals, even the journals that Professor Lockton publishes, like The Lancet. There is overwhelming evidence that it's harmful. And within the setting of a big controlled trial from the osteoarthritis done by a chap called Professor Mike Doherty in Nottingham, they took over 800 people and treated them for 13 weeks, which is quite a long trial for this type of study. And they showed that paracetamol didn't work. But then when you use paracetamol and ibuprofen together, there was more blood loss, so the hemoglobin levels went down. So you should not be using that combination. If you find paracetamol is really good for you, for a headache, then take it, but I wouldn't take it regularly. And there is obviously a real question about what the role of paracetamol, because it's already used as the drug of choice for suicide, unfortunately. So it's something.
9 years ago, so it's probably a bit before the time of the research.
So that's another take home. Be cautious about using paracetamol.
I remember a couple of years ago,
Yeah.
there was a talk that when you saying about ibuprofen and paracetamol combined being bad. And again, that was an osteoarthritis meeting. Are you talking about paracetamol more particularly in relation to osteoarthritis, or are you talking about it generally?
The published meta-analyses I'm referring to, including the Costa meta-analysis, were done with osteoarthritis and low back pain. And that, the editorial related to that paper was quite strong in saying that there wasn't a role. Obviously, the difficulty is paracetamol at the moment is used very widely, it's very cheap, it's very widely available, and we don't have a good understanding. And because we don't report toxicity, so if somebody has a bleed, even have a life-threatening bleed, and go into the hospital, it wouldn't even be recorded or yellow carded that they were on paracetamol, which is something we need to change because the controlled evidence within an RCT has shown that level of toxicity. And we've talked about the grades of evidence, but big trials give you better answers than small trials. And when you have a blinded study, it avoids the problem of bias that a lot of science is affected by. So we know that this is a robust trial.
So just a quick question.
Cool.
Last night I had raging toothache for
Oh,
4
yeah.
hours in the middle of the night. It was hurting my ears and hurting all my teeth. And paracetamol didn't touch it. What was I supposed to do?
Well, it depends what else you had in the house at that time. Did you have any ibuprofen?
Yeah, but I thought you couldn't take that, so I just would be
Well, have a glass of milk, have a snack, and then take some ibuprofen.
What's the alternative?
The alternative would be to use physical measures. So if you've got a toothache or a headache, then sometimes having a hot bath will help, or getting a cold compress. So heat and cold are quite good ways of blocking pain. And obviously if the toothache then goes on, it's all about access to healthcare, isn't it? In this case, emergency dental treatment. And it depends on how good. So it's all about knowing what to do at the time and how to access the system.
So is the widespread use of paracetamol a placebo effect really rather than anything else?
It would be a placebo if it didn't do any harm. I have to say that the guidelines are long overdue for review, and they are going to be reviewed. And so I think we need to watch and wait. Watch this space. I'm going to pass on that. So it's my great pleasure to introduce Ellen Hayes, who's going to talk to us about exercise and behaviour.
Hi, so I'm going to keep it quite short and sweet. But as John said, I'm studying my master's here this year. I've just come from Exeter where I did 3 years of sports science. And my main role up here, unlike these people studying arthritis and spending all their time in the lab, true to form, I spend most of my time in the gym trying to get older adults to do some more strength training. So we've just done a feasibility study where we're basically trying to find out if older adults will do the strength training we ask them to do, and if they will drink the milk that we ask them to drink, because we think that that might also help the adaptations that we see to strength training. So we're getting people to come in twice a week, and they do 4 exercises, which isn't a lot. It lasts about 25-30 minutes the session. And they'll come downstairs, they'll drink their milk, and we send them on their way. I can't tell you if the milk's helped yet, because we're just seeing if they drink it. But I can tell you that most of the people that came in decided that this was a good intervention, that they'd be happy to carry on doing it. One of the main benefits we saw from it is that people actually started to make friends within the group. So we have 2 women that have become really good friends, so they now go to the gym every week together and then go for coffee after, which is quite nice. We've also seen that a lot of people have improved their hand grip strength. It's a machine that I think Tony's going to talk more about later. If you want to pass it around, you can test your hand grip strength. But this is
a few instructions for how they.
Yeah, there's just an on button and you squeeze it.
Yeah.
It's pretty simple.
I think Professor.
Okay. Yeah, which is a really good marker of health, and we found that a lot of people have improved that. And we've also had a lot of people that have come in with neck pain, knee pain from osteoarthritis, that have said that actually doing this strength training has improved that pain. So we're seeing a lot of good things at the moment. I'm going to do a bigger study hopefully on it next year to let you know if the milk helps. But for the moment I can tell you that exercise is good. So I'll pass on to Ellie, Tony.
Well, before we pass on, yes, questions. Nice try.
Both you and Fraser have emphasised exercise.
Yes.
Are you okay to use the microphone?
Yes, of course. If you have your hip replaced in Gateshead, I'm told, then you get off at the kind of exercise session that you've talked about. If you get your hip replaced in the Newcastle Hospitals Trust, not only don't you get any physiotherapy at all, except for the brief time you're in hospital, but you are actually refused physiotherapy when your doctor refers you. Why is that?
I'm not in the position to say. I don't work in it.
I think Tony might be the person to cautiously answer that.
So
it's hard for us to comment on individual care.
It is hard to
Well,
comment.
it's not individual, it's a blanket ban by the musculoskeletal department.
So I can't comment on individual hospitals. I do know that certain areas have different commissioning groups, so certain health services are commissioned and aren't. That's out of the hands generally of the surgeons and the staff. It's more at a high level that they look at the evidence and say, we believe that this intervention is worthwhile or not worthwhile financially and for the patient. So we can't really comment on that individual case, but there is variability in the hospitals. I can talk, when I'm speaking a bit later, I was going to talk about genetics, but I can also talk about some other research I do looking at grip strength and also things like what we call rehabilitation. So I will mention that briefly later on, which is a new field of, not new, but new in terms of medicine, a new field of looking at improving outcomes after surgery. So I will mention that during my talk a little bit if people are interested to hear about that.
Question for you. For your research, are people referred to you because they have a problem, or do you have a group, control group, who you're not treating, but you're preventing for that particular group of ending up coming to you for treatment?
Okay, so none of our participants we've had have
Do you want to
been...
summarise the question? Because I'm not sure that will have been heard with a report.
I think it was just almost
About
like where do we recruit our participants from?
Yeah.
So yeah, a lot of them aren't referred by the GP. They don't have any pre-existing problems. The way we recruited is we asked GPs to send out information to all their over 65s, and they read the information. If they wanted to participate, they did. So we've had people with all conditions, etc. People with no conditions. Yeah, it was run on a volunteer basis, basically.
And that's quite a good design. So if you want to get an answer that includes everybody, we generally view the list of patients attending a GP as being quite a good list. It doesn't include everybody, so the people who are rough sleeping or not registered with a GP wouldn't be included, but in general that's one of the robust approaches to use the age-sex register.
Yeah, I'm a great believer in prevention rather than cure, before cure. Hence the reason getting a control group to say, look, they came through X number of years later, they still haven't been referred because there's no need to. Now, whether or not that might have happened as a result of the exercise, I don't know whether the research could prove that, but I'd sign it.
Yeah. Unfortunately, this is the first one we've done, so we don't have any long-term data. But yeah, it's we're trying to improve muscle mass and things like that in all adults. So hopefully, they should be better off when they're finished than when they came in.
No, John.
I'd sign it.
Are you still taking volunteers? Or would that be...
I'm not. You'll have
Not
to ask my
at
boss.
the moment. Not at the moment. I think if people are keen to participate in research, then there is a mechanism through the Voice website, and many of you will have seen, to kind of flag interest when topics come up there. And if people have a burning desire to be involved in research, then please ask us questions at the end.
Just about exercise. Do you research for people who do extreme exercise, endurance sports? I mean, I was thinking at the weekend there was an Ironman event on Keswick, and that really is extreme. It's 2.1 miles swim, 112 mile bike ride, and then a marathon. Do you look at people who do that? I mean, they look incredibly fit.
Yeah, so funnily enough, I've finished a study this morning that looks into masters athletes. So we've had over 55s come into the lab, and we've got them on their first day to do some muscle damaging exercise. So we've done 140 squats. Some of them weren't too happy with me at the end. And then they've been on a moderate protein diet or a high protein diet for 2 days afterwards. We're trying to see if the high protein diet will speed up their recovery, so prevent muscle soreness, etc. in the 48 hours after exercise. Again, I'm not getting results yet.
But you think they are doing okay? I mean, it's not too much exercise.
Oh, no. So I think it was the 2017 Ironman. I think the top 50, there's a couple of 50-year-olds, a couple of 55-year-olds that actually got to the top 7% of times. So I think if you can start and you can keep going, then don't stop.
Not me, my son is doing it.
But that's great, because I think that is a strong message that comes out. It is use it or lose it, and those people who do exercise can sustain more.
Can I have one question on exercise, please?
Final question before we move on.
Heart rate. Now, I pump mine up now to 220. Is that dangerous? I'm 80 years old.
Okay, so I answer that one. So our goal with moderate exercise is to get your heart rate up to 85% of maximum. 220 is pushing a little further than you'd usually want to. You're in the vigorous exercise range, and if you can do that, that's fine, but you don't need as much of it to get the benefits. So the benefit would come from only 75 minutes per week. In general, you wouldn't want to sustain that level of exercise on a prolonged basis.
20 minutes.
Okay, so that's...
Each session,
okay.
daily.
Well, the thing is, you're doing it daily and you're doing it regularly. And in that setting, it's beneficial. The trouble is that exercise has quite a dual effect. So actually, when you're acutely doing exercise, there is a small risk of arrhythmias and problems with the heart. But then, when you do it regularly, the sustained long-term benefits are greater than the small risk from doing a small amount. So the fact that you're doing it every day and you can still sustain that level tells me that it's the right level. And if you started feeling faint afterwards, or keeling over, or you started getting any chest pain or other issues with it, then that would be a red flag and let you know that maybe it's the time to get it checked out. But good on you. So if we'd asked that question earlier, you would have said, yes, of course I do. I do that amount of exercise.
So what is 85% from that?
Well, obviously it's kind of age dependent. In general, most people's target heart rate for moderate exercise would be to get up to the 160 to 180. There is a chart, again, you can look up online if you're not certain. But if you're getting out of breath, so one of the things I tell my patients about is, if you're walking the dog and you never work up a sweat and you never get out of breath, You're not doing enough exercise.
You know me well.
Obviously. I don't know you well, but I know everybody, the population. You know, my PhD was in epidemiology. I'm used to looking at populations and seeing what happens and interpreting the people I see and where they fit in there. We need as a population to move and all do a bit more. So it's really inspiring to hear examples of people who are at a more advanced stage are still doing lots of intense exercise, because that's already you're up there, and the rest of us just need to move along a little bit and do a little bit more.
I was always told, sorry if we're prolonging this, that a lower heart rate was good.
Well, the thing is, a lower heart rate is partly inherited and it's partly trainable. So a lower heart rate is good because as you get fitter, your basal heart rate goes down and your response, your recovery after the intense exercise becomes quicker, the recovery. So as an example, I suspect once you've taken your heart rate and it goes from 220, when you stop exercising, I'll bet within 2 minutes it's bang, right down, which again is a very good sign. So that's the other marker that we would use. Okay, we're going to move on because all of these questions and all this discussion is really good, and we very deliberately left lots of room for potential one-to-one discussion at the end because we weren't sure how much people would want to contribute and how much people would be held back by the web streaming. The answer, of course, is not at all, and there's been lots of good questions. So I'm now going to introduce our next speaker, so Ellie Parker, who's going to talk about our genes and our joints. I'm looking forward to this.
A little bit. So I'm Dr. Ellie Parker, and I'm a research scientist, and I work here at Newcastle University with John, down at the Centre for Life. So at the moment I do look at genetics with John, and I mostly study osteoarthritis, and I've been studying osteoarthritis for about 8 or 9 years now, ever since I first started my PhD. And during that time, so at the moment I look at genetics, but during that time I've looked at osteoarthritis from many different levels, many different perspectives, like big level looking at the whole joint, all the way down to DNA now. And so when I first did my PhD, I was interested in exercise, which we've just been talking about, and how that affects the joints, and how it affects the cartilage within the joints, and the cells that are within the cartilage. So in the cartilage you have a single cell type, one type of cell that's called the chondrocyte. And what I was doing was, I was looking at to see if the type of exercise you're doing, so kind of a high impact exercise like running, for example, particularly running on a hard surface like a road in a marathon, or low impact exercise such as cycling, and whether those different types of exercise had different effects on your joints, on your cartilage, and on your cells. And I was also looking at whether you did those different types of exercise in the morning or in the evening, and whether that had a different effect on your joints. And what I found was that if you were going to do some high impact exercise like running, you should really be doing that in the evening and not in the morning. And the reason for this is during the day, when you're sitting or standing or walking around, what happens is the weight of your body is kind of compressing your cartilage, so it's pushing out fluid and liquid, and what that does is it makes the cells inside your tissue, the cells inside your cartilage, smaller, so they're a bit more protected. So what you see when you exercise is you see less kind of cell stress indicators, so it's signs that the cells are a bit unhappy and might be dying soon or things like that. Cells replace themselves, so cell dying is not a really bad thing, so just look at that. And the other thing that I looked at during my PhD was I looked at the use of kind of common supplements that you do buy at health food stores and things like that. Things like chondroitin sulfate or glucosamine sulfate. Sometimes they're sold in combinations. I think Joint Ace is one combination you can buy. And I was looking at the use of those. And so what I did was I directly put those compounds onto the cells, and then I provided some kind of mechanical impact onto them to see if they helped. And whilst what I saw was they did help, and the way they helped was by making the cells smaller and helping protect them more. The problem with these supplements is that I was putting it directly on the cells. And when you take a tablet or eat it with your food or anything like that, you're eating it and it's going into your digestive system and it's not going anywhere near your cartilage. Because cartilage doesn't have any blood vessels, and the way you get medication when you take it through your mouth is that you digest it and it goes into your bloodstream, and that goes around your body and gets to where it needs to go. But because cartilage doesn't have any blood vessels, it cannot get any of these supplements. So whilst, yes, they may work if you could put them directly in the cells, taking them orally is not really going to help you at all. And I also stress that this isn't a treatment, it's a protective mechanism. So you were talking about prevention earlier. This would be a preventative measure. So there's really no way of us getting these supplements to your cells in a way that's safe that you'd be able to do every day to help prevent yourself getting osteoarthritis. So kind of that's what I did before I came here to Newcastle. So since moving to Newcastle, I've started looking at genetics with John. And as he spoke about earlier, he was saying about how we take big data sets of people that have osteoarthritis and people that don't have osteoarthritis. We compare essentially their DNA, and we're looking for kind of tiny differences, tiny mutations, if you like. So, DNA is a series of letters, so this would be like a single letter change between someone that has osteoarthritis and someone that doesn't. And then what we do is so there's about 90 or so that have been found so far, these tiny point mutations that are more common in people that develop osteoarthritis than people that don't develop osteoarthritis. And what we do is we look at these mutations and we look to see if they're doing something and what it is they might be doing. And one of the measures of this, one of the things we look at is called epigenetics. And the way I like to kind of explain what epigenetics is if you think of genetics, your DNA, as kind of a book or a script that makes you who you are, epigenetics is like the editor. So it edits it and it decides kind of which bits get read and how much they get read. And epigenetics is what makes every cell in your body different. So it's what makes a bone cell different from a blood cell. Because they both have the same DNA, they both have the same script. It's the editing that makes them the two different types of cells. It's also what makes us all different, the epigenetics. And so what we do is we look at these edits, these differences, and we look to see if they correlate with the mutations. So if there's a link between the mutations and these edits. And that's what we really do at the moment. And what we find is a lot of these mutations, the 90 plus that have been found so far, a lot of them are linked to editing changes. So the next step, which is kind of where I'm at now, what I'm starting to look at now, is what these edits do. So kind of what proteins they affect, what genes they affect, and then what that protein does and how that protein can perhaps be involved in osteoarthritis and how that might help people develop osteoarthritis. So that's kind of why we're...
Excellent. Any questions for Anna?
Yes. Really,
microphone?
That's really interesting. Thank you. Stop me if I've got this wrong, but from what I'm hearing here is that you're suggesting that with epigenetics and this editing, we are not just looking, but these are essentially environmental factors that can change genetic performance. But doesn't that undermine the whole history of the doctrine of natural selection that we've had for 150 years, which has specifically excluded environmental factors?
You are correct, there can be environmental factors. There is a genetic component to these epigenetic editing, which is what we're seeing here with the links between the mutation and the editing. That's a genetic component, but epigenetic does have a large environmental factor as well, so things like smoking and aging, in fact, can also change the editing as well to change these epigenetic factors, and like exercise as well, lots of things, your diet, where you live, where you grew up, things like that can affect your editing, your epigenetics. John has something to say.
Yes. Yeah, I mean, it's a very small point, but the thing about epigenetics is that we don't see any great evidence that it's transmitted in the germline. So if it's not transmitted in...
Yeah.
So
it's having a big influence for us as individuals, but it's then not. We haven't overturned Darwin's theories, don't we? I don't think they're regarded as theories anymore. Not by most people.
No, it's not. It's a very good point.
I think it's really a testament to how clearly Ali explained that certainly the questions and the insights is so correct. Well done. And any other burning questions? Because obviously we do need to dash on, so...
Can I just ask a very quick one? Is there a difference...
We're just going to get the microphone.
Is there a difference between you describe an edit and where I've heard this description of there's a piece of the genetic material missing on a certain part of the DNA? Is that different? Is that two different things?
That would be something different. So when I'm talking about editing, the baseline code is still there, so the DNA is still there. It's just kind of been blocked from being read.
Oh, right.
So it's kind of like, one of the mechanisms is called methylation, which kind of creates like a covering over the DNA, which means it can't then be read, so the protein for that bit, that gene isn't made. So it's still there. So when you have talking about in that way, it means it's missing the actual baseline DNA sequence missing. That would be quite a large scale mutation.
And would that mean that that could cause an underlying disease or something like that.
If you had a large piece of DNA missing, then
or even a small piece, if we're talking about a rare disease.
Yes, yeah.
Yeah, that's
yeah,
right.
exactly.
So, with the issue we were discussing before, if the DNA itself was missing, that could cause an inherited disease.
Right.
But if it was the gene actually being expressed and you getting it copied and active in the cell, that could lead to somebody developing a disease in life that then wouldn't be passed on. So it's quite a challenging concept, but I'm really delighted with the way that people are asking questions. It's helping us to explore. Science is about asking the right questions and getting honest answers. And when it doesn't fit, when your hypothesis was wrong, that's one of the most valuable things that there is in science. So medicine and science moves forwards by asking difficult questions and answering them very robustly. And that's one of the things that we really wanted to try and get across today. So I'm delighted that we've soon to achieve that. I'm going to pass on now to Tony.
Thank you, Fraser. So I'm going to actually talk a bit about what Ellie spoke about, but also a bit about what I do, which is the same but slightly different. And I've said I've got some other research interests if people wanted to hear a bit about prehabilitation and grip strength. I'm happy to talk about that as well. So my name is Tony, I'm an orthopaedic surgeon, I'm also an academic, and in the UK there is very streamlined pathways for people to do surgical academic training, but they're very sparse. So, for example, nationally there'll be 4 or 5 jobs a year. The reason for that is because we have service pressures. So for someone like me to say, well, I'm going to go into the lab for 6 months, they'll lose a doctor in the hospital. So that's why these jobs are hard to get generally, but there is a few of them floating around. In the Northeast, for the last 6 years, we've had an orthopaedic training number with an academic component. So there's 6 of us in a line that are all doing the same thing. We take time out to do academic research. So I went to medical school like a normal medical student. In my 4th year, I was worried about getting a job, so I thought, oh, I'll do a master's degree. And I just thought that would be fine. Ended up in a lab and absolutely loved it. So when I was a 4th year medical student, I was studying cartilage like Ellie, and looking at growing cartilage from human cells, from healthy donors and from people who are older, and seeing whether that cartilage, those cells could make better or worse cartilage in those people. And ever since then I've been researching osteoarthritis. So I came to Newcastle in 2016 and I came to John's lab. I've been working on, again, epigenetics and genetics, but because my interest is surgical, I'm more interested in seeing how we can take that information, what we know about genetics and epigenetics, and apply it to patients. So I'm interested in what we call translational medicine, translational epigenetics and genetics. The main gist of that, and what John alluded to, is trying to see if we can take this information we learn about why people who have these certain point mutations get osteoarthritis and use that to make a stronger cartilage. There's various ways to do that. One of the things we talk about is something called regenerative medicine, which people may have heard something about, the concept of regenerative medicine. It's using patient cells and tissues to grow new cells and tissues. And the reason that's good is, say, for example, you have a problem with your hip or your knee. We can put a metal knee in, but it might fail, you might get an infection, things like that. If we can actually understand the disease better, we can develop treatments that can be delivered in drugs, and also that can be delivered in the sense of taking a patient's cells out of the body, growing cartilage from them, and putting them back in the patient. And by understanding the epigenetics and genetics, we can understand what proteins are causing the disease. So the last few months I've been looking at using some technology called genome editing. I know I spoke to the voice group before about things like this, to look at whether you can identify genes that cause a disease and turn them on or off, or just get rid of them completely, and then see if you then grow cartilage from that, whether it's stronger, with a view that helps you understand the disease, it helps you understand that protein is causing the disease, but also it can be a treatment in the future. And again, if we can find drugs that can target these specific proteins or these specific mechanisms, we're quite a long way away from that, but that would be the gold standard. It could prevent us doing operations. Like you said, hip replacements are very good, but actually knee replacements aren't the best operation we've got, and we need better treatments. You talked about prevention, and obviously prevention is better than cure. If we can find drugs that can reduce the development of the disease, or treatments that can help us treat arthritis better, that's the best way to approach it. That's what I'm interested in. I will just briefly speak about rehabilitation, because some people are asking about it. So some of the research that I look at as well looks at grip strength. So I know you've all tried the device today. We know that grip strength is a really, really good marker of how sarcopenic you are. So I know John mentioned this, it's about muscle wasting, and actually that's a really good marker of how healthy you are. So we know from big studies that just testing people's grip strength alone can give you a really, really good idea of how healthy they are, even when we look at other conditions. And they followed big cohorts of patients. There's a Professor Alan Sayer here who followed patients in Hertfordshire. They did a big study, and they showed that just testing a patient's grip strength and seeing how much that dropped, if you followed them, was a really good indicator of whether they'd get on well or whether they'd die. So the grip strength is very, very strong predictor of these things. So it's really interesting to see everyone using it. The reason I'm interested in things like that is because we're wondering whether we can potentially prehabilitate people. So there's some good evidence that if you take patients before they have an operation and say to them, well, actually, we're going to send you to see a physiotherapist for 6 months before we do your major surgery, they'll do better. And I was in Dublin a couple of years ago, a professor of rehabilitation from Italy spoke, and interestingly, in their patients who were undergoing major surgery, the most effective rehabilitation was psychological rehabilitation. So over every other treatment, intervention, nutrition, supplements, and physiotherapy, what they found was that if you took patients and put them in a room and said, your operation is going to be hard work, you're going to struggle, it's going to be sore, you're going to be in bed for at least a week, but after a week we're going to get you up and you are going to get up and it is going to hurt, they did better in every outcome. So it's just interesting to see the power of those kind of interventions. The reason I find that interesting is because in terms of the grip strength, if we were going to do hip and knee operations for patients, we could potentially bring them into the hospital, test their grip strength and say, well actually, you're a bit below what we want, and we could send them away. As you know, there's waiting lists, so you've got 6 weeks, 8 weeks before you can have an operation. Send them away for 8 weeks, give them physiotherapy, give them nutrition, give them counselling, bring them back for their operation, and we predict that they'll have better outcomes. So that's another thing I think is very interesting. I might be taking any questions about that.
Great. Any questions?
Does it matter if the grip strength's different in each hand?
Not really. So you will have a dominant hand grip strength and non-dominant hand grip strength. I know because I've actually had a major operation last year where I injured my hand, so I had to learn a bit about this outside of my research life. But generally, if you take 10-15% off your dominant hand, that should be your non-dominant hand grip strength. There is some scales for age, and as we've all gone around, we'll have given a score. Everybody's different, and actually our grip strength declines over time naturally anyway, as I've spoken about in the essence of sarcopenia. But you will have a normal for your dominant hand that we can look at a scale and say, yeah, you're normal, above average or below average, and you'll have the same for your non-dominant.
Could I ask about arthritis in your fingers? I thought it was with taping. Having to thump a typewriter really hard, and apparently that's not wear and tear.
You probably know more about this than
Well,
also the grip strength. I can't close my hand.
Yeah.
I've got pain all the time.
So let me take you back. I told you about doing my PhD in Manchester, and there were some very famous epidemiologists who did work in Manchester. Some really seminal work. Guys called Kelburn and Lawrence. And they actually kind of invented a scoring system which is still used in X-rays today. They got a great big X-ray truck, and their research was funded by a forerunner of Versus Arthritis and Arthritis Research UK and the Arthritis and Rheumatism Council. It was called at that stage the Empire Rheumatism Council. So this was research in the 1960s. They got a great big X-ray truck, and they drove it out to the outlying areas around Manchester, including Lee and Wensley there. And at that stage, there were different occupations. There was still a lot of mining, there was a lot of heavy industry, and they did meticulous epidemiological research, that's research in the community, by looking at true populations, the way that it should be done. They didn't have clever computers, so their analysis was quite basic by our standards today. And yet, by taking a very good population sample, having meticulous records of what people did, they showed very clearly that there were certain occupations associated with particular sorts of arthritis. And in my PhD, we did a large survey, and we also looked at an inception cohort of people developing osteoarthritis of the hip, and then saw what happened over time when they first presented to the GP. And our work showed that actually hip osteoarthritis is still very common in farmers, and it seems to be related to walking over rough ground. So while secretaries and heavy typewriters, there's not a lot of that going on now. No, and that wasn't a specific group that Kelburn and Lawrence looked at. But their work tells me enough to know that it's very likely that in your case, that very heavy load was important for your osteoarthritis. In general, what we see is that, and you mentioned about dominance with strength, we're usually stronger on our dominant side. So who's right-handed? Okay. Let's assume the rest are left-handed around here. I'm a left-handed. And apparently there's two sorts. I won't tell you what sort. So the key is we are stronger on our dominant side. We use it more. So it's stronger from use and exercise, and strength comes from that. And Ellie's explained why that's the case. But then it's also more common for you to get arthritis, both osteoarthritis, because you use it more and there's more load, but also when you've got inflammation, you get more inflammation in the side you use more. So an extreme example would be if you had a stroke and you don't move one side of your body, rheumatoid arthritis goes from being a very symmetrical disease with equal inflammation in both sides to being much worse in the side that you move. Okay? So that helps us to understand, how use is important in driving inflammation, and to a lesser extent, the episodic inflammation that characterises osteoarthritis. So in terms of the tear, the flare, and the repair, all of those processes are affected by your day-to-day use and habit.
All self-inflicted.
You could argue that. But did you enjoy it?
Yes, I did.
There was a really long pause. But...
I've just got a question for Tony, and I've just proved to myself that my grey cells aren't regenerating as well as they used to, I don't think. But fundamentally, I heard about some work which, I may be wrong about this, but I think it involves 3D printing a part of the joint, and then, or use an unscientific word, infusing it with stem cells, and that would grow into the proper joint, which would have much less rejection issues.
So my master's, the actual full title is Tissue Engineering for Regenerative Medicine. So that's the tissue engineering component, which ties into what we do. So thanks to MRC and CIMA, I was actually working in a tissue engineering lab in America in February for 4 weeks, with a view to going back there, because what they do a lot of is scaffold work, seeding human cells on scaffolds. The interesting thing about that is, like you said, you can 3D print these scaffolds which are porous. I was going to mention, but I didn't actually, there's other specialties that are ahead of us in cartilage, so tissue engineered bladders, so there's 3D printed scaffolds of bladders, or what we call decellularized, so take a bladder from an animal, take all the cells off it so it doesn't react with human tissue, seed it with the patient's own cells and grow it back. There's been 10 of those transplanted in the world already, and it's been incredibly successful. That is something we want to do in arthritis tissue engineering. There is a lot of people doing cartilage tissue engineering. It's something that I'm looking to do in the future.
And that's been done with animal bone as well, hasn't it? There's been whatever you said.
Correct. So we use decellularized bone matrix as well. We use it a lot in orthopedics, actually a lot of porcine, so from pigs. So we get decellularized bone matrix sometimes when we do orthopedic surgery. We have large bone defects, and actually you just put the scaffold in, which is essentially bony tissue without the reactivity, because your body doesn't recognize it as alien, and your body builds around that scaffold. So that is the other component of what is tissue engineering and regenerative medicine.
I'm going to hand on now to our final speaker. Thanks, Tanya, who has already been introduced, so needs no further introduction.
I'm still going to say hello again. So I wanted to talk a little bit about my research. I mentioned already that I'm a pharmacist, and the reason I decided to do a PhD in this area was because I spent a lot of time, about 8 to 10 years, working on the wards in hospitals, in particular orthopaedic surgery wards. And I have seen the impact that diseases like osteoarthritis, osteoporosis, and fractures have on somebody's quality of life, has a really kind of important impact on your function and your ability to do day-to-day tasks and so on. And I felt it was quite important that that's the area I wanted to look at. And so I've started my PhD. I'm in my first year at the moment. And my study involves osteoarthritis, osteoporosis, which is where you have brittle bones, and sarcopenia, which was already mentioned, but sarcopenia is about muscle wasting. The PhD involves a big cohort study. I don't know if anyone's heard of it, but it's called the Newcastle 1000 Families Study. Some of you are nodding. It's one of the oldest long-running cohort studies in the world. It started in 1947, and it took more than 1,000 people who were born in the months of May to June of 1947 and followed them from birth, and now it's in its 7th decade of follow-up. And it's a really special study, and the reason it's special is because we have loads of data about the participants. The participants were called the red spots, so on their GP records they would get a little red sticker to say, you know, you're part of this study, all of your information will be collected, so if you have kind of any fractures or any events across your life course, you can take that information and store it and use it for lots of different reasons. And not only that, we have lots of kind of specimens, so blood tests, we've got scans of bones, we've got you know, lots of different types of imaging that we can use. And importantly for me, we have stored blood samples at 2 time points, at ages 50 and ages 62. And what my study involves is taking those blood samples and extracting the serum, which is a component of blood. And what we're looking for are little pieces of code called microRNAs. And they're quite hard to explain what they are. But if you think about DNA is a double helix. The structure of it looks a bit like a ladder that's been twisted. Well, microRNAs are much smaller than that, and they only have 1 strand. And they are a kind of form of editing, as Ellie was talking about there, an epigenetic change. And what they do is they kind of bind to pieces of code and switch genes off. So it's a bit like kind of silencing the genes that are expressed. And if you do that, then sometimes proteins won't be made. And what's important about microRNAs is that it can be expressed in different ways. So if you get abnormal expression, that can lead to diseases. And what my PhD looks at is looking at the risks across the whole life course of developing the 3 musculoskeletal aging diseases, whilst looking at kind of other risk factors at the same time. So things like whether you smoked or not, whether you were breastfed, whether you had a good diet, whether you exercised, and what the influence of those influences is on your microRNA pattern in your blood. And also we want to know what microRNAs tell us about whether you're going to develop that disease or not. So do you have a different level of microRNA in your blood that can tell us whether you're going to develop one of these conditions or not? So essentially it's looking for the association in your blood with this code and developing one of those diseases. We're also interested in looking at aging itself as well. So as you get older, do your microRNA patterns change? And can your body, can we predict how well you're aging? Are you aging faster than your actual chronological age? So it's quite interesting to know about that, and whether there are certain things that speed up the aging process. So the reason that we want to do this is because the diseases that we talked about, especially osteoarthritis, has very few useful treatments to help with its progression. We don't have a drug that can kind of cure arthritis. But what we can do is certainly look at microRNAs as targets for treatment, because microRNAs are little bits of code that you can switch off and on with a drug, and the drugs that are in development at the moment are called oligonucleotides. They're basically a little bit of code that switches off the microRNA. And there has been some studies already done, mainly in animal studies, that have shown that you can actually improve cartilage in animals, rat models, by using drugs that switch off or on your microRNAs. So it's a really interesting field, and the microRNAs will be useful as a kind of measure of whether you are likely to develop one of these diseases, whether you're likely to respond to treatment, and also as potential treatment itself. So I think that at this point in time, I'm only in my first year of the PhD, and we're certainly looking at some interesting findings with that. So, thank you. Any questions?
Thanks very much, Tanya. So that's raising the prospect. We are going to age grace, which is quite surprising.
Yes.
Any questions for Tanya? Has anybody heard of telomere shortening? Because at the moment there are a few things which are already used to measure chronological age.
Would you say that again?
telomere shortening. The reason I mention it is that there's a chap called Thomas von Wielinski, who's a great, scientist who described telomere shortening, and it's one of the ways that we measure aging. So, do you want to comment on comparison with that? Are we going to be able to compare it to that?
Well, yes, hopefully we should. With the Newcastle 1,000 Families study, as I mentioned, we've got lots of stored specimens, and we do have data about telomere shortening, so kind of cellular data. And also we have information about other epigenetic changes. So microRNAs are a form of epigenetic modification, but we have information about DNA methylation as well. And what we want to do is kind of compare whether microRNAs are a better predictor of biological aging than the already established methods. So that's one thing that we definitely can do, because we have data from our participants on all of those different things.
Great. We've run to time, really. Obviously, we've embedded all the discussion and the interaction, the questions within the mock group. So thank you all. I'd like to thank our speakers. Thank you very much. And I'd like to thank the audience for such a fantastic set of questions. And it's always a marker of science that is explained well, that it does promote questions and you start to unpick and understand things a lot more. So thank you for coming and challenging us today. And hopefully, when a group consultation appears at a surgery near you or a hospital near you, you'll be slightly less surprised about it. Because where our title today came from, Better Together, the evidence behind the headlines, was that we were speaking last October at a meeting in Glasgow, the Royal College of General Practitioners, and there was 3 journalists in the audience who were in touch with us afterwards, and they'd rather said they weren't planning to run the story. And of course that wasn't quite true, because it turned out that it was on the front page of The Sun, the Daily Mail, it's always the Daily Mail, and also the Daily Telegraph. Not all of it completely accurately recorded, but was it P.T. Barnum who said there's no such thing as bad publicity? I think one of the things is, it's really important that the patients who have the experience, and the reason why we're invited, the patient and I, to speak on BBC News afterwards, was really to explain that the people who've been there and seen it are almost all enthusiastic about this model of care. And the people who haven't seen it often say, gosh, I don't fancy that. And that's all well and good. We're only promoting it really as a way of trying to deliver better care and to give better access to care. And so,
was it Look North, where I saw TV clips on your
it might have been Look North. I think it was run very widely.
It was, but I did see about your clinic in Alnwick.
It's an amusing story that I can share, because it turns out we were asked to go in, I was asked to go into the studio in BBC in Newcastle, and I was saying, well, will I bring my other patient down from Alnwick? And they said, oh no, we've only got 1 camera, so we can't possibly interview 2 people at the weekend. But it was run initially on Lunchtime News, BBC, where the interview was done. And then what the BBC does now is they then put everything online, and they put it on the radio and everywhere, and there's lots of saturated covered and lots of things picked up by the Jeremy Vine show and things, and interviews on the Today programme. So, please do give us your feedback. Please fill out the questionnaires. Please feel free to stay for a short while to finish off the refreshments and the fruit. But I think we do need to be out of the room shortly. So, thank you all, and signing off to our web audience. Thank you all.
Thank you.